Hi everyone, thanks for joining our webinar. Our topic today focuses on negative pressure rooms and other go-to strategies for air quality management in the dental operatory. My name is Adam, Content Marketing Specialist with Schein, and I'll be your moderator. There will be no live Q&A following today's presentation. If you have additional questions about this topic that cannot be answered by today's presentation, please send us a question via the chat tool and we will get an answer to you as soon as possible. This webinar is sponsored by Schein Dental, and no CE credits are being offered for viewing this presentation. Our speaker today is Dr. Mark Tholen. Dr. Tholen has lectured extensively all over the world and is the author of 3 dental textbooks. His career in dentistry spans over 30 years, including clinical practice before obtaining his MBA. Thank you, Dr. Tholen, for presenting for us today. Over to you.
Well, thank you very much for the introduction, Adam. I appreciate that. I'm really excited today to be able to make this presentation to you because I and my architectural team have been working pretty much daily on being able to find these go-to strategies for improving air quality management in the entire office and specifically within the dental operatory. Now, we've got this image on the screen of the electron microscopy of a COVID-19 virus. And this image is a great representation of the challenge to optimize the safety of our patients and also our staff from cross-contamination. But it's only one of many, many microbes that we need to consider in securing our dental environments. So I and my architectural team are working in real time with real offices and with real doctors to supply practical, cost-effective solutions to this microbial challenge. And I'm just going to emphasize that again, that these are practical, cost-effective solutions to meet this challenge in our time now. And our focus has been and is an effective use of office space and effective air quality management to serve as an additional barrier technique in our offices on a daily basis. Now, in an earlier webinar, I addressed the use of office space in being able to minimize cross-contamination and enhance our patient perceptions of safety. But this program will address how a new or existing office can be retrofitted to improve air quality management and to minimize the threat of microbial aerosolization. Try saying that one 5 times in a row. Tough word. So here's the challenge. Aerosols that we must use in the treatment of almost all patients. And, of course, we all have localized methods of aerosol management with intraoral, high-speed and low-speed suction. But this program is going to focus on what we can do to manage the significant aerosol cloud that escapes that evacuation effort. And I think, true air quality management has largely been ignored in the design and construction of dental offices. But my architectural team have designed dental and medical offices for decades, and we are using the best practices of hospitals, research labs, and clean rooms in air quality management to mitigate risks. But here's the problem. Valid protocols designed to prevent COVID-19 transmission do not exist. And so we're implementing spatial and air quality redesigns on the fly in real time. Now, we're using lessons learned from Ebola and TB in the development of these redesigns until we better understand the COVID-19's pathways of transmission. Spatially, the dental office can be divided into 3 zones: clinical, public, and private. Now, we went over this on an earlier webinar, and I guess this is just a little bit of review. But we're most concerned with this blue clinical zone because this is where the treatment is delivered, and this is where the aerosols are created. It's ground zero. So we're going to focus on air quality management in the operatories to minimize and contain the aerosolization of viral and bacterial particulates. And because dental care is mostly elective and care of the medically compromised patient is generally deferred, there's going to be a hyper focus on individual patient care rather than on unit care. That's what you would mostly see in a hospital. And so I'm going to have specific recommendations for the overall clinical zone and tailored recommendations for a single operatory that will be able to be designed with airflow management to treat the emergency dental patient with a respiratory infection of undetermined origin. Here we have a graphic of how air is going to be moving through the operatory. And you see with the blue lines that the air supply should originate in or near the ceiling, with the clean air pushed in a downward trajectory. You can see where those blue arrows are coming down to a return air grate. And those return air grates should be placed at or near the floor of each operatory, because a large part of air quality management is the correct airflow throughout the operatory. And the concept is to drive the air and the particulates downward and away from the face of the staff. And this airflow discourages and reduces the continued aerosolization of viral particles and aerosol clouds inside the operatory. So consider using this methodology in each op in which aerosol is generated. And you can see the return air is indicated with the red arrows taking the recirculated contaminated air back up to the air handler and to be going through the filtering system. Now, this particular schematic that you see on the screen is generally employed in in warmer regions of the country, because the biggest thermal challenge most of the year in those areas is heat. But in more northern climates where the weather is much colder, much longer, the most common practice is to place the air supply grates at or near the floor and the return air in the ceiling. So it's just the opposite of what is on the screen. And so if you're in a more northern climate, this may be exactly the opposite of what you have right now. But our concept, again, is to drive down the aerosols away from the face of the staff and the patients and down to the return air so it can be filtered. Now, speaking of filters, let's take a look and think about filtration for just a little bit. Okay, it's really, really simple. Use a HEPA filter. We're done. Okay. No, I mean, if we want to rid the recirculated air of virtually all microbes and other particulate matter, then we want to use a HEPA filter. Now, this filter uses a very defined weave pattern, and it also employs a tunneling effect to screen microbes out of the air. Think of a labyrinthine maze as the air passes through the filter. So virtually all particulates, whether they're viral or bacterial or inanimate, are captured inside a HEPA filter. But a catch to this is the filter requires an upgraded mechanical system to pull the air through the filter. So it's more expensive. And of course, oh gee, how much more expensive? Well, the cost of an average commercial heating and air conditioning system, HVAC system, is approximately $4,500 per ton. Now, if I'm you, I'm asking, okay, well, how many tons do I need? Well, the average dental office needs 1 ton of air conditioning for every 275 square feet of office space. Most general contractors will tell you you can get by just fine with 1 ton for every 400 square feet. And if you were running an accounting office, something like that, that would be just fine. But a dental office has much more physical activity in it. And so what we need is we need more air conditioning, sometimes even in the wintertime, even in northern environments. And so we're going to have 1 ton of AC for every 275 square feet of office space. Now, if we're going to use a HEPA filter, when I said this is more expensive than just a standard commercial system, okay, the cost is doubled. So now instead of $4,500 a ton, it's going to cost us $9,000 a ton to have a HEPA filter system installed in our office. Okay. Now, what about negative pressure? And what's the relative cost of that? Well, the cost of a negative pressure on a per square foot on a per ton basis is double that of a HEPA filter. So now we're up to $18,000 a ton for a negative pressure room. So I'm not going to recommend that we're using negative pressure throughout the clinical zone, because you'd be spending hundreds of thousands of dollars on an HVAC system. And honestly, I don't know that it's that effective. And so, but this is what we will recommend. Consider using HEPA filtration in at least the clinical zone, and have separate heating and air conditioning zones for every architectural zone. In other words, we've got a heating and air conditioning zone for the clinical zone, one for the public zone, and one for the private or staff zone. And this way, you don't have a war of the thermostats. And if you have the team working in the clinical zone and they want it cooler, they can turn the air conditioner down, and the people in the public zone won't be cold, and the people in the staff zone won't be cold. In addition to filtration, UV light placed in air handling units can reduce or inactivate contaminated airborne particulates before air passes through the filter. UV light with shorter wavelengths is very effective in deactivating infectious aerosols. But however, UV light is not commonly placed in commercial heating and air conditioning systems, and it's not very efficient in larger commercial systems. So if you're doing a 15 to 20 op office, it's probably not going to be very effective, because the air is moving so fast through the system. And especially with the air exchanges we're going to suggest per hour. But having said all that, I would say that it's not a normal and usual and customary request. And so this is used with some frequency in residential units, but not in commercial units. And when we're using a HEPA filter, UV light is somewhat redundant in our armamentarium of being able to recondition the recirculated air. But if you're going to use UV light, you want to use UVGI light, because this particular wavelength is indeed germicidal for all viral and bacterial particulates. Now, besides filtration, besides UV light, another issue that we need to consider is controlling humidity in the office, because this is an important factor in managing a virus, because survival of the membrane-bound virus decreases with increasing humidity. And what research has found is that the relative humidity above 40% is detrimental to the survival of the coronavirus. And this relative humidity also decreases airborne dispersal. And if we think about it just a second, oh, that's right. A higher humidity in a room is going to encourage the formation of larger droplets in the aerosols in the air, causing them to deposit onto surfaces more quickly. So they're not floating around as long. So we're going to maintain a relative humidity in our offices between 40 and 60%. That's the current recommendation. But most, okay, and here's the caveat though, most built-in humidifiers are not common in commercial systems because of mold considerations. So maybe a much more effective way of handling this is to use portable room humidifiers placed strategically throughout the office. And that's going to really help with the overall management of humidity in the office. Now, you know, while it seems, I mean, I know we're talking about some things that are kind of what I call more high tech. Well, here we are with an awfully low tech thought, and that is to use these cues throughout the office. And these signs and floor cues are very effective in reminding people to observe basic practices that can serve to reduce microbial transmission. And yes, I know it's incredibly elementary, but increasingly we're finding that these are extremely effective in helping reduce transmissions. Now, let's move on to the topic of negative pressure units for just a minute. You know, there's been increasing interest in the use of negative pressure rooms in dental offices. And traditionally, these rooms are in hospital emergency rooms. And most of those emergency centers are equipped with one or two negative pressure rooms, and that are actually built into the hospital mechanical system. They're part of the hospital infrastructure. And these rooms are used whenever an aerosolized procedure will be performed, such as an intubation or bronchoscopy, or the treatment of a patient with possibly communicable upper respiratory infection. But hospitals also have mobile negative pressure units that can be used when demand surges. And you can see one of these units in the image here on the screen. Now, these units, these mobile units, have been used with great effectiveness very recently. And here's a graphic of an intensive care unit that was a full unit, and on the fly, these individual beds within the intensive care unit were turned into individual treatment rooms and individual intensive care rooms. So this graphic illustration shows how negative pressure mobile unit is actually used. In this case, the hospital enclosed all of their intensive care beds into individual rooms, incorporated the negative pressure mobile units into each room, and vented the exhaust to the outside. So the concept is that no air leaves the room, okay? So more air is leaving the room that is entering the room, so that no contaminants are spread to other areas of the facility by airborne transmission. And this is a good example of a retrofit solution to create a negative pressure room. But I'm going to say that almost always retrofits are unique workarounds because the infrastructure of an office varies. I mean, in this example, the hospital was fortunate to have intensive care unit on an exterior wall for venting, because they had to vent every one of those mobile negative pressure units to the exterior. And so just a comment about retrofit projects. They've got two components. One is conceptualization, or what I call just a general plan, kind of like what you see on the screen. That's a general plan. But actually accomplishing the installation with detailed mechanical, electrical, and plumbing architectural plans, that's a very different issue. okay? And very different approaches are needed for a freestanding building as opposed to, you know, the interior space on the interior lease space on the 13th floor of a multi-story building, or, installing a negative pressure unit in a 100-year-old building in which a new dental office is located, because we get all kinds of materials that we have to negotiate that used to be considered normal, and now they're considered very, very hazardous and dangerous. And there might be structural issues of the building that have to be worked around. So most retrofit projects are almost always uniquely tailored to that particular environment. Now we have a another example of a retrofit, but this one does not utilize a mobile unit. In this case, access to a drop-down or suspended ceiling and adequate ceiling space allowed the retrofit to actually be installed. You can see where the air supply is coming in. They're using fresh air coming in on this particular example. And the fresh air had to be conditioned, you know, either with heat or with cooling. And now the air supply is, as I said, being thermally conditioned with either heat or refrigeration, and there needs to be an outside or fresh air component to this. Now, you know, it won't be 100%. Generally, it's going to be anywhere from 10 to 40%. So the vast majority of the air in the space is recirculated air that's passed through a HEPA filter, but there is a fresh air fraction or an outside air fraction of 10 to 40% that's actually being introduced. And the amount, the percentage of fresh air is dependent upon building code in your particular locale. And it could be building code that's in your locale. It could be a national building code specific and peculiar to health environments. So there's a ventilation component that has to be mixed with the recirculated air. And outside air can be introduced into the heating and air conditioning system by adjusting the outside air dampers on the air handling unit, either mechanically or electronically. Okay? So we don't have to make this decision ahead of time. We can actually adjust it during the use. And if we want to increase the fresh air supply, we're able to do that, you know, in real time, as long as we have these either mechanical or electronic controls on the air dampers in the air handling unit. And this allows us to exhaust or expel a higher ratio of the inside air, the recirculated air, and therefore rid the office of any airborne viral particles present. Now, in addition to ventilation, we also need to consider the room air exchange rate, okay, as well as filtration, which we've discussed, air turbulence, which we will discuss, and relative humidity of the air, which we have discussed. Now, all of this is addressed by the architect and by the mechanical engineer on the project. Okay? So again, the devil is in the details, and while there can be a general idea of how we're going to accomplish this, actually handling it in the detail requires detailed architectural drawings, as well as very specific construction documents, that is to say, assembly instructions. Now, let's talk about the exchange rate for just a second. Operating rooms have a room air exchange rate ranging from 20 to 30 times an hour. And right now, what I've heard is that OSHA is considering mandating an air exchange rate of 6 times per hour in most commercial facilities. I'm going to have a list of recommendations later in the program that's going to include air exchange rates, but just as a preview, we're going to be suggesting somewhere to 12 to 15 times per hour for air exchange in operatories. Okay, just in operatories. So within the HVAC system that controls the clinical zone. Here is a floor plan graphic, and it's going to demonstrate an ideal location for a negative pressure operatory. Notice the green shaded operatory in the lower right-hand corner. The door to the clinical corridor that serves this operatory also separates the clinical corridor from that particular op. And so the negative pressure can be created in this particular operatory while providing dual rear entry to the operatory for the dental treatment team. And what we're trying to do here is create the negative pressure environment without increasing the physical stress that is so present in the office, and we're trying to maintain the efficiency with a minimal number of steps and minimal movement in the office and the operatory, so that we maintain a high level of efficiency and productivity in the office. And even though we're doing treatment in this negative pressure environment. Now, this door can actually be designed to be sealed to ensure a negative pressure environment. And so now, once that door closes, the HVAC system it is incorporating the negative pressure elements into it, or whether or not we've got a mobile unit retrofit or some other fashion of retrofit in that particular operatory. This configuration vis-a-vis the floor plan, I would consider to be ideal. And this is what we've worked out with the architects being able to create a highly efficient environment. Also, this particular space can serve as a surgical op as well as a quiet op. So it has many different purposes. When the team is exiting from the compromised emergency patient op, that is to say the negative pressure op, I'm going to suggest a couple of things on the operatory side of the door. And one is hand sanitizer, and the other one is a waste disposal unit. And perhaps some tape on the floor that we're leaving a highly contaminated area. Just put your brain in here. And so we want to have all of the disposables placed in a sealed waste disposal on the as the staff is leaving the operatory. And then we also want to have the staff using hand sanitizers. And I would suggest that once you leave this particular space, you also, necessarily will have changed your mask, okay? And do not touch the exterior of the mask, okay? Very important. We don't want to touch, because, there might be contaminants on the exterior of the mask. So you take the mask off, drop it in the waste disposal, and then exit the room. Here's the treatment team actually working in the operatory, and we know that viral particles can be directly deposited and then resuspended due to natural and mechanical airflow patterns. And these resuspended viral particles can then settle on fomites, that is to say, objects or materials that are likely to carry infectious disease, such as countertop surfaces or the surgical gowns that the team is wearing. And fomites can be contaminated with the settling of aerosolized viral particles and droplets also. Now, we're currently working on the assumption that COVID-19 can persist on fomites from 2 hours to 3 days, depending upon the material. Now, recently, the CDC has made an announcement that that COVID-19 is not living on external surfaces for any really significant period of time. And that's fine. But we're going to continue working on the supposition that COVID-19 is a lot like other viral and bacterial particles, and until we have more definitive research on this particular virus. But I will say this, transmission to date has been documented only through respiratory droplets and not through fomite deposition. So people aren't, I shouldn't say they're not picking it up from contaminated surfaces that are touched by multiple individuals, but there have been no documented evidence of this. So, you know, the team would be wearing masks. You're wearing surgical gowns, you're wearing gloves, and if you're using exam gloves, I'm going to suggest that those are changed every 30 to 45 minutes because the latex begins to break down after that. But otherwise, if you're using surgical gloves, they'll last for your entire procedure. And then I'm also going to suggest in this photo, the team is not wearing head covering, but I would suggest wearing head covering, and I would also suggest wearing shoe coverings. Now, I'd be remiss if I didn't spend a minute talking about the mask, okay? And I'm thinking this is especially important for the staff when you're treating patients. Use an N95 mask, please. N95. Okay, it's your new best friend because it filters the viral particles, including the COVID-19, and you know it's going to be your first line of defense, and maybe it's your best line of defense. You know that and a face shield and or glasses. Now, here's what I would call the caveat. You may need to take some oxygen breaks with this mask because some users become hypoxic. Okay? I mean, I know when I wear a N95 mask for any extended period of time, I'm just really happy to take it off and take some deep breaths of fresh air. And sometimes treatment teams in emergency rooms need to have oxygen breaks where they literally are breathing oxygen for a while after having worn these masks. So give yourself a couple of minutes between cases to take this mask off, take some deep breaths, get a drink of water, take a break for a second, because these masks are a little bit of a challenge to the team who is wearing them. Now, and I mentioned this before, but it bears repeating. You know, hospitals are now using signage as mental anchors for specific activity and behavior reinforcement as a significant part of their armamentarium in infection control. You know, colored paint, signs, and colored tape alert staff to the levels of risk they encounter in a variety of spaces. And for example, these mental anchors remind staff when to wash their hands and when to don personal protective equipment. But staff lounges have been found to be a significant area of infection. So it's recommended that mental anchors be used outside your staff lounge, urging staff to wash their hands before they enter the staff lounge. And I mean, look at this diagram and look at the key, and you can see all of the areas that serve as fomites in this diagram. It's amazing. So, you know, just a word of caution, be careful, wash your hands, and for heaven's sakes, don't walk in with contaminated clothing on. Now, it should be noted, however, that again, and I'm restating this, that transmission of COVID-19 has not been documented through fomite transmission. It's been documented only through respiratory droplet spread. And so, it may be this may be a straw man that we don't need to worry about, but for the moment, we should. Now, you're taking so many different precautions with your patients. For heaven's sakes, tell them. Your patients are not going to know what you're doing unless you communicate this. So I would be sending out a newsletter, an email to all my patients, and letting them know what we're doing, and that we've really taken this to heart, and that we're concerned about what is happening with them. And it never hurts to actually say that you are the experts on this, and that indeed you really care. I mean, why not? Why not? A lot of times people don't know unless you actually say it. So let's not be guilty of lack of communication and omission of our sentiments and our efforts. Now, here are some recommendations for treatment of the compromised emergency patient. And these are going to be in addition to all the recommendations for non-emergency care that immediately follow this slide. But we want to use a sealed operatory and consider a negative pressure up, either one that has built-in infrastructure into the mechanical, electrical, and plumbing infrastructure of the office, or a mobile unit, or some other retrofit that's been created for at least one operatory in your office. And we want to be sure we are employing waste bins for all trash in the operatory, and then we seal that waste bin, and then a biohazard company can come and collect it periodically. Now, here are some considerations for non-emergency care. First of all, the heating and air conditioning air supply ducts should be placed in the ceiling or high on the wall, and return air is going to be low toward the baseboard in every operatory. Consider using HEPA filters in the air handler in at least the clinical zone, heating and air conditioning zone. And we want to consider increasing the outside air fractions. In other words, the fresh air component to the recirculated air in our office to somewhere between 10 and 40%. And we want to have an air exchange rate of 10 to 12 times per hour. Consider using UV GI light in the air handler. But as I said, this is not usual and customary in commercial systems, and it really is not efficient in the larger commercial systems. And if you're using HEPA filters, it may be somewhat redundant. We also want to have a relative humidity established in our office somewhere between 40 and 60%. I mean, you're going to find it's much more comfortable the closer it is to 40 rather than 60. And the way that most of us are going to accomplish this in our office is through portable humidifiers that are strategically placed throughout the office to maintain that humidity. And I would say, of course, the most critical area is the clinical zone, but of course the public zone, which would include the front desk as well as the waiting room, as well as the consult room would be another area. And then the staff zone, where the staff goes without patients, would be another area of concern. As in the staff lounge, that would be a biggie. That'd be a biggie. And also, one element that we have not addressed yet is just the airflow itself. we want to try and create a laminar airflow. And if you tell that to a mechanical engineer, they understand exactly what we're talking about. What that is we are minimizing the turbulence of the air as it comes out of the air handler. It comes out as if you can just think of a smooth sheet with no wrinkles in it at all, or water that comes out of a faucet and it looks like a clear ribbon. We've seen those types of almost waterfall-like faucets, and there's no turbulence in the water at all. And that is a laminar flow. And so we want a laminar airflow so we don't have eddies and turbulence in the air, which is resuspending viral and bacterial particles in the air. And lastly, for all of us, I would say for the immediate future, we want to be using head coverings, gowns, gloves, face shields, shoe coverings, and N95 masks. Now, I know we've covered a great deal on this particular program, and so if you need to reach me, you can. I can be contacted at Dr. Mark at mynewdentaloffice.com. That's the name of that's the name of my website, mynewdentaloffice.com. There's a blog there with a number of articles that you can read also about the design and the construction of dental offices. I have written 2 books on the subject of dental office design, and some of the elements that we've discussed here today are in the books also. And both books are available at Amazon.com. And the last thing I'm going to leave you with is that all the information you've received today is what I call real-time information, because I and my architectural team continue to design and be involved with construction of offices all over the United States. And as we do, we're addressing these issues, and also we are working with offices all over the country in retrofitting facilities with the recommendations that I've made today. So know that all of the information here is exceedingly current, and it's all what I would call real and practical information. So thank you very much for your time today, and I wish everyone the best in being able to reopen their offices and engage their return of their patients and having a wonderful summer. Thank you.
Thank you, Dr. Tholen, for this great information and very important content. And thank you to everyone for attending today's webinar. Everyone who attended will receive today's recording in the coming week via email. On behalf of Henry Schein, thank you, Dr. Tholen, for your presentation. Enjoy the rest of the day.